Good morning, friends and colleagues, brothers and sisters, dental professionals and medical professionals from all across the world. Today we got a little surprise guest for you, world famous Dr. Thomas Wiedemann, who is a medical doctor as well as a dentist and oral surgeon with countless degrees and a very long resume. I'd like to quickly introduce him. Thank you, Dr. Thomas Wiedemann, for joining us.
Thank you, Dr. Shah, for inviting me. It's really a pleasure. I'm very happy to be here.
Absolutely. We are going to talk a little bit about your background. You have been with us since 2014, I believe, with the Extraction Academy, and we have trained thousands of doctors over the years in different topics. And one of the topics that we have noticed over the years that have been very desired by our colleagues are complications, which you often talk about. But a little bit of background: Dr. Thomas Wiedemann, MD, PhD, DDS, is a clinical assistant professor, is currently a full-time faculty member, assistant director of advanced programs in oral surgery, Royal College of Surgeons of Ireland at New York University, College of Dentistry, Department of Oral and Maxillofacial Surgery. Dr. Wiedemann's career consists of more than 26 years of surgical and educational experience in academic settings and successfully operating private practices, providing the full spectrum of oral and maxillofacial surgery and implant dentistry. In addition, he offers 14 years of professional experience as senior consultant in healthcare management and as an expert witness. In addition, he is a fellow of the European Board of Oral Maxillofacial Surgery and has diplomat status in the International Congress of Oral Implantologists. His special research interests are minimally invasive surgical techniques of the full scope of oral maxillofacial surgery, medical and dental emergency care, ceramic implants, titanium intolerance, peri-implantitis and implant failures, surgical complications management and implant dentistry, a hot topic, and oral surgery. He has acquired extensive experience in implant surgery with multiple implant systems, titanium and zirconia, since 1995, and is well versed in innovative concepts of bone intra and extra autogenous bone graft, extraoral autogenous bone graft, soft tissue regeneration, CBCT guide, and piezosurgery. Dr. Wiedemann has lectured extensively domestically and internationally and conducted hands-on courses on oral surgery topics, implants, and bone graft procedures all over the world. So, Dr. Wiedemann, you've been quite busy in your career, have you not?
Absolutely. Every day is a busy day, but there's always time enough to give a webinar for you, my friend.
Thank you for joining us. I understand you work at New York University and you're in the forefront of the COVID matter in one of the hottest states and also one of the top universities in the country. We use this opportunity to bring our colleagues together at our home to look into advancing their knowledge and skills and become part of our objective of reaching as many doctors as we possibly can during these hard times. So I also see that you're starting to do now that the world is starting to open up again, you have a lot of different workshops scheduled this year with us in July and August. There tend to be the major football cities, and the information on them can be easily obtained on extacademy.com to join us at these one-day workshops across the country. And Dr. Wiedemann is going to take the lead and is a course director. And we've been doing this for quite some time, and it's very helpful to transition doctors from exodontia into implantology, and we are the right people to help facilitate that, and I appreciate all your participation and the other faculty members. So with that said, Dr. Wiedemann, I'm going to go ahead and switch over to your presentation, and let's go ahead and get this one also hit. There we go. Please proceed, Dr. Wiedemann.
Okay. Hello and good morning from New York City. And thank you again, Dr. Shah, for inviting me to present this webinar. That it's really a great honor, and I'm very humbled. And I consider this as a really a highlight.
Certainly.
Well, I have, during the past weeks, I have certainly observed numerous webinars in your organization, and they all showed the absolutely bright side of implantology and all the great things you can achieve. For some reason, I was choosing to show you a little bit the dark side of implantology. And that's why my topic is the etiology and the clinical management of surgical complications related to dental implant procedures. I believe that the study and elimination of complications is the most fertile field in implant dentistry at this point of time. Already back in 2010, Dr. Eckert, editor-in-chief, International Journal of Oral Maxillofacial Implants, wrote this in his editorial. And also the guidelines of the Academy of Osseointegration, stating, in particular, the ability of the practitioner to predict, recognize, and treat complications from the treatment is of paramount importance. By reading this inspired me a while ago to set up a lecture and a lecture series on these kind of topics, the greatest complication of all. Yes, so the intention of my lecture is to raise awareness of typical surgical complications and also how to avoid and manage these complications. And those of you, and I think that's the majority, they have placed a lot of implants. And you may agree that masters have failed more times than beginners ever tried. Now, what's our situation nowadays? Our situation is that more and more people are choosing dental implants. So the number of individuals with implant complications is increasing. And these procedures are no longer limited to specialists. More and more clinicians who may have not advanced training are involved in implants. So some of these surgical complications, they might be really relatively minor, easy to handle, but on the other side, we have major complications, and they not only result in the loss of the implant, no, they can even result in permanent damage of adjacent anatomical vital structure, or sometimes can be even life-threatening. I understand we all want to have successful treatments, but what is success? What is a successful treatment? Well, if you look that up, it tells us aim or a purpose. And that makes a failure simply the lack of success. And we have to find a way to come from here to there. So I want to ask a question, and I even try to answer this question during my presentation. And this question is implant success already the lack of complications? And are complications ultimately the result of poor decisions? Let me give you an answer. First, I want to start with the definition. What is actually a complication? Well, I looked it up. And what I found is a complication is a secondary disease or condition aggravating an already existing one. Yes, and that's how it feels on both ends. Yes, we don't feel well. We are getting worried, and also the patient is unhappy. Provider and patients are usually unhappy when it comes to complications. In my personal experience in dealing with complication, I can tell you for sure, no matter what kind of complications we are failing, whether this is early implant failure, late implant failure, surgical complications, biological complications, mechanical complications, ultimately it always comes back to the one who placed the implant surgeon. So this lecture is technically not about why do implants fail. This has numerous reasons. Here in this lecture, we definitely want to focus on implant failures related to poor surgical practice, or maybe wrong and poor decisions. So I divided up this lecture in surgical complications as far as they are related to implant selection, in positioning, to injuries to adjacent anatomical structures, and also to medical and even life-threatening complications. Complications in implant dentistry, they may already arise just how we select our implants. We can select them too long, like here, or we can select them too short. We can select them with a diameter which is way too wide, or like here, which ultimately affects bone level adjacent teeth and the long-term outcome. Or we may select them too small. Nevertheless, even before placing the implants, we may create conditions they will ultimately lead into complications. So we also, before we even place that implants, we should make sure that all kind of granulation tissue is removed from the implant site. There is an absence of infection, because infection sites should be really thoroughly debrided, and a bleeding should be initiated to reduce the bacterial count and to increase the bone growth factors on this side. And also we should pay attention on our adjacent teeth. So all kind of endodontic treatment, apical surgery, extraction of this adjacent tooth should be really completed prior to the placement of implants. So already at that stage, we can start to avoid complications. And also during our implant surgery, it's always important to have a good surgical technique. Yes, we want to avoid heat. We want to avoid pressure. We want to avoid over-torque when we place our implants in order to avoid complications. So all kind of oxidative stress to the bone should be avoided in order to minimize potential complications. And then when it comes to malpositioning of implants, to the positioning itself, many different mistakes can happen. And I will give you some examples. Yeah, that's the typical example. An implant in the aesthetic zone is placed in the wrong way and is unrestorable. And this, well, it didn't happen anywhere. It happened even in the aesthetic zone. So in this situation, the only cure is to remove the implant, to compensate for the defect, and to provide this patient with a new implant. Same here. This implant was placed as a needed implant, and most likely it was not considered that the axis of the tooth and the axis of the future implant is not the same. In this case, it probably would have been better to use a surgical guide to place this immediate implant. And also here, placing an implant within and only doing flapless surgery. I have no problem with flapless surgery, but here in this case, we already can see something is going wrong, and we made the flap. You could see that this implant is not where it's supposed to be. And the same here. If you only have a crestal view, this implant may look even wonderful, but once you open the flap, you see how this implant was positioned. And here I have more examples, here and here and here, and also here. And sometimes these implants are even getting restored, and they show really very unfavorable result. And you can believe me one thing, I could show you 20 slides more of examples of malpositioned implants. Implants are not usually only placed too much on the buccal, they also can be placed too much on the lingual or on the palatal side. And if we try to restore them, it's either not possible, or we get these unfavorable ridge lap superstructures. But placing the implant in the right position is not so complicated. Already Boozer published multiple articles on how to appropriately place an implant. We always should make sure that implants are placed in the comfort zone and not in the danger zone. And we all know, if you have a situation like that with multiple misplaced implants, it may take up to 15 or 18 months to newly restore these patients, to remove this implant, do the bone grafts, placement implants, and finally come to an acceptable results. So my recommendation is really whatever surgical guide you want to prefer, as one surgical guide is better than no surgical guide. And you get them as non-limiting or completely limiting, it doesn't matter. Whatever is appropriate in the situation, I'll be fine with that. If we place more than one implant, there is always also a good chance that we are violating other biological principles, like the tooth implant distance or the inter-implant distance, like we see here in these situations. These implants are unrestorable. If we would restore them, this will have a detrimental effect on the implant itself and the adjacent tooth. Or here, these implants here, they are literally engaging within themselves. Or here, how you want to establish a proper hygiene. And this is what happens if you try to restore them. Yes, then you will face the biological consequences. You will see, the bone will literally get necrotic. And also here, these implants are way too close together. The biological principles have been violated. And ultimately what you get, you are facing implant loss and you're looking into a significant bone defect. Yes, and I remember this person. She had implants placed, immediately restored everything within 2 weeks. About 3 weeks later, she came and she had a swelling of the gingiva, pain all over the place. When I flapped it, that's what I saw. Yes, and that was pretty much my reaction. There wasn't too much we could do with this patient unless taking out all the implants and starting the case from zero. But the implant placement itself is not enough. Even in the post-operative phase, complications can occur technically at any day. Even in early phases, we all know that. We may face into an incision line open. The implants are getting exposed. Well, that might be easy to fix. Also here, next step, our mucosal flap is getting necrotic, partially or like this. Or we are looking into a full necrotic mucosal flap, most likely due to insufficient flap design, overstretching the flap, or this situation. This patient didn't have actually pain, came as an emergency patient, but you can see this wound healing problem, the necrotic flap. That's not even the only problem. Yeah, if you have a close lock, look, you see the position of the implants. That's going to be really very challenging to obtain a favorable aesthetic result. So when we combine implants with bone grafts, we may look into early complications, like a premature membrane exposure, like in these situations. And this happens actually pretty often. Once we use a DPTFE membrane, an exposure is acceptable and you may still get acceptable results. But if you use a collagen membrane, well, you may look into problems. If we are lucky and we can establish a good oral hygiene, you see on this example, although this is the case of one of our residents, even if the membrane exposed, by establishing a good oral hygiene, you can fix that complication. But sometimes, yeah, we may have to remove the membrane and have to resuture and remove the membrane, because we know a bacterial contamination of the membrane has an effect on the soft tissue and ultimately may even compromise the regeneration process. It's not only the membrane which can be exposed. We're also looking into a situation where the entire bone graft is getting exposed. To a certain extent, we can fix that, fortunately. Like here, once the graft is exposed, we might be able to cover the exposed bone graft with a split flap and the situation is resolved. But sometimes it all starts with an incision line opening. The next step is the bone graft is getting loose, getting mobile. We're looking into a non-union, and the bone graft is getting lost and has to be removed. So a key feature when it comes to how to avoid exposure of implants, bone grafts, membranes is how you design your flap and that you make sure the flap is tension-free. Because one thing is for sure, soft tissue management, that's what it's all about. The flap makes it or breaks it. So always try to achieve a tension-free primary closure and a good wound stability. So that for this reason, it's very important that we understand all the contributing factors, like the amount of keratinized tissue. How is my flap? will I be able to obtain a good primary closure? Complications may not be limited to the implants itself. They also can spread out to adjacent anatomical structures. I was told to wait a year as the feeling might come back. Yes, I certainly believe this. Yes, nerve injuries. In this study, all these type of nerve injuries have been investigated very thoroughly. And we know that nerve injuries has become the second leading cause of all types of nerve injuries when they are implant related, up to 17%. This is even a higher percentage of nerve injuries related to implant placement than the third molar surgery. So in this study, they could show that they're looking in more or less like 13% of short-term incidences. Short-term is anything less than 10 days after surgery. Yes, after 6 or 12 months, many of these nerve disturbances, this altered sensation, they may result. But we still look into like 3% of a long-term incidence of nerve injuries. And nerve injury is not necessarily related to the implant placement itself. It can also appear just by your flap design, how you make your incision, especially in a situation like this, with a highly atrophic mandible. And not even the incision, or how you retract the flap, or how your assistant is reflecting the flap. Stretching in injuries are quite common due to excessive reflection, retraction, or even suturing the soft tissue, especially when it comes to bone grafting. Like, we need a bigger flap, we have to retract more, and that's how it happens. And we also know, like this study from the Bursa showed very impressively, when we are dealing with implant-related nerve injuries, most likely we look into a kind of permanent neurosensory disturbance compared to third molars, endodontic surgery, and all kinds of other surgery. Why is it like that? Yes, nerve-related nerve, they are rather permanent than temporary. Because with our drill, with our implant drill, or with our implant, we may even cut or at least severely damage this inferior alveolar nerve. We may even look into a partial or complete transection of that nerve, and that's no longer neuropraxia. Now we are looking into axonoptosis and even neuroparesis. Why is it like that? Yes, sometimes we underestimate even our implant drills. We should never forget that the implant drill itself, due to its wide dimension, is always a little bit longer than the actual drilling depth. So for this reason, I highly recommend the use of drill stops. Another problem is, we all know that situation. The width of the crest is not wide enough. So by evaluating this, we always have to make sure what kind of procedure we want to do. We want to reduce the crest in order to obtain more width, or we want to do a graft procedure. Important, no matter what you do, measure from the point where the platform will be placed. And if you are shaving all this off, of course, you have to choose a different implant. So especially if the ridge is compromised in width after osteotomy, really make sure that you choose another type of implant, so you still can maintain a safety zone of 2 millimeters. Also carefully with immediate implants in the mandibular premolar area. Their mental nerve can be really very close to the root tip. So we really have to understand that many immediate implants in the, especially mandibular second premolar, we will have to obtain primary stability. So we may drill apical to the apex, and that neurovascular bundle is literally waiting for us. We have to understand the mental foramen is right inferior to the second premolar in almost 73%. And in, let's say, in about a third of the cases, the mental foramen is even superior to the premolar apex. So really careful when we're placing immediate implants in the premolar area. Ultimately, it always breaks down to how well we perform a radiographical evaluation of our patients. Yeah, many implant-related nerve injuries are the result of inadequate planning. Yeah? You have to have a good awareness of the amount of bone availability before we place an implant. And here this study shows post-implant neural damage, 90% a CBCT was not used. 48% of the injuries resulted from inadequate radiographic assessment, or here 50 or 54%. So that's quite a big amount. Yeah, and it starts all that we are able to identify our IN. If you have a pen like this, I am not able to identify our inferior visual nerve. Yes, we have to understand that there might be an absence of corticalization, especially in cases where the trabeculation is decreased. Yeah, in a normal trabeculation of the mandible, most likely we will be able to identify our mandibular colony in almost 80% of the cases. If the trabeculation is decreased, it goes down to less than 70. And yes, and we also have to understand it's not only about the trabeculation. We also have to understand that a pan is distorted and has a kind of unpredictable magnification. It's non-uniform. We have to understand that. You see that here, especially here on you get a very non-uniform magnification in the horizontal plane. That's completely inaccurate. If you know your pen very well, you will be able to get an idea of the vertical magnification. Yeah? So considering this, you still will be able, up to a certain extent, to determine the vertical length, the vertical bone availability of your implant. But the horizontal dimension is entirely inaccurate. So what to do? You place the implant, you do your post-op x-ray, and what you see, well, my implant is in or at the mandibular canal, and you may even look into an altered sensation. I can tell you, in this case, this patient had no altered sensation. In this case, yes, this patient had a neurosensory disturction. So what to do in this case? Yes, important. You can't determine an involvement of the IN only by using a pen. You will have to do a CBCT evaluation. And once you did this, and you determine, is my implant really touching or even impeding my inferior velar canal, you may have to do the call. Should I reposition, replace, or remove my implant? What's the best thing to do? In a situation like this, where we have a CBCT and we can identify that this canal may be violated, but it's not really transected. Yeah? That neurovascular bundle might be still intact. Yeah? A good idea and would be at least to remove it, to back it out. Yeah? Because if we don't do it, yeah, this may even end up in a neuropathy. Yeah? So an early removal will definitely help to this patient to come to a partial or complete resolution of that nerve injury. But our approach in this case is quite different. This canal is completely transected, as we see here. So we clearly have to distinguish when we are dealing with this kind of situation. On one hand, the canal might be violated, but not transected. So decompression is very important. We back out or even remove the implant, and we also help that patient with a kind of medical decompression by administering anti-inflammatory drugs. Once the canal is transected, the nerve damage happens. I think it doesn't serve any purpose to remove that implant. The nerve is destroyed. So in these scenarios, it's much more beneficial to have a really very early surgical repair and even keep the implant. So a primary neurorrhaphy in this situation and having that implant in place would be a much better approach to help the patient. So my recommendation, If these things happen, a systematic approach to the management and even an early referral for evaluation and possible nerve repairs is highly recommended. If you only impinge the nerve, yeah, I always recommend use dexamethasone, topical dexamethasone. This will definitely reduce the inflammation and reduce the compression from swelling, and then the nerve may recover much faster. Of course, we will not graft and place an implant in this situation. On the other hand, what's left if the damage is happening? There are different surgical approaches, like a decompression, or if you wait too long, you will look into a neuroma formation. Yes, this part has to be excised and the nerve has to be reconstructed. Nowadays, we use kind of no longer autografts. We use this, for example, advanced kind of allografts and to help the nerve to regenerate. This is certainly also a field where we look into future therapeutic concepts like stem cells. Future is yet to come. But there are also these situations like this gentleman who had implants placed somewhere outside. He waited and waited, hoped for the best. And after 6 months, of course, there was no sensitivity, but the implants were perfectly healed in. So in this situation, to remove the implants doesn't serve any purpose. So these implants got restored. And please watch out. Meanwhile, 24% of claims against the American dental insurance companies are related to nerve injuries. And some law offices, they are kind of specialized in that. They are actively advertising for that. And this gives you an idea. This is a lawsuit from the state of Florida. And finally, the case was settled with $633,000 US due to an implant-related nerve injury. So my advice, yes, prevention. Measure and plan really well. Place these implants in a safe distance and confirm the correct position immediately after surgery by doing an X-ray. An ounce of prevention, believe me, is worth a pound of cure. But also other anatomical structures might be perforated. We may look into migration or even displacement of implants into other anatomical spaces. So an intraoperative displacement into the maxillary sinus can happen, actually quite often. Here. Also here, this person didn't give up. 3 implants dislodged into the maxillary sinus. This might be due to poor bone quality, poor surgical techniques, or sometimes implant placements without a bone graft, or especially in needed implants. These are scenarios where an intraoperative displacement into the maxillary sinus can happen. But also a post-operative migration of implants into the maxillary sinus is possible. Different theories have been described in the literature, from changes into the intrasinal pressure to bone destruction secondary to infection or even peri-implantitis, improper distribution of occlusal forces. So here, you see here, this implant migrated even through the entire sinus lift. And once these implants are in the sinus, they love to migrate. Like this implant migrated already to the ostium area and was occluding them. Once they are there, they may even migrate here, almost here into the nose and have to be removed. Or this implant migrated into the ethmoid sinuses here and here and here. Again, another situation. This implant here migrated all the way into the ethmoid sinuses. And that's not enough. Once they are there, they may even migrate into the sphenoid sinus, like in this scenario. Or here, this implant is dislocated in the intraorbital space into the orbita. So here, even close and even right underneath the optic canal. Although this implant was placed 5 months ago, and the patient showed up with a kind of sudden discomfort in the left zygomatic area. And the implant was found here really right at the posterior wall of the maxillary sinus beneath the optic nerve. And yes, and even there is one case published in the literature where an implant migrated into the anterior cranial fossa. Fortunately, it could have been removed. The dura could have been reconstructed, and the patient survived. Yeah. Yes, and that's a situation where you may think, I shouldn't have placed that implant. Even that literature overview, it shows us typical locations where implants may migrate. And we see the vast majority migrates into the maxillary sinus and even remains there. Only very, very few exceptions. And once it's in the sinus, we have technically two surgical approaches how to recover that implant. We may look into an endoscopic approach. It's more or less on the ENT side. Or we can look into a direct approach, a cultural lock approach, which can be performed to recover these implants. And that's how it looks like. Yeah, a lateral window is being deformed, and then usually not a complicated procedure to recover an implant. Well, implants not only get displaced in the sinus, they also can perforate right here into the nasal cavity. And of course, these implants should be removed, also like here in this scenario, because they may have a negative effect on the nasal airflow and even can cause some scar formation. If you're using zygomatic implants, well, implants may even penetrate here into the orbital floor. And here, like in this scenario, transect a lateral rectus muscle. Or here, this patient showed up about 1 year, had chronic, 1 year after surgery, had chronic severe headache from the first day of surgery and had a zygomatic implant placed right into the brain under general anesthesia. Perforations not only happen in the maxillary arch, they also can happen in the mandibular arch. And in the mandibular arch, they're typically rise either in the anterior segment or very much in the posterior segment. Why does that happen? Yeah, flapless surgery is one of the reasons, as we see here. Here and here, two implants are perforating the lingual plate. And even here in this scenario, this implant was placed displaced into the submental space during stage 1 surgery. And it was identified here, 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 here. Unfortunately, this implant was not palpable, so it had to be recovered from an extraoral approach. And the only reason was lack of primer stability, perforation of the lingual space. Of course, what happens in the anterior part of the mandible also can happen in the posterior part of the mandible. As long as we have a mandibular arch with that parallel shape, the chances are really very low. But we have to be aware that especially in the area of the second lower molar, we may look into these concave-shaped mandible arches. And that's where the trouble starts. And here you see, in this kind of concave-shaped mandibles, there is a good chance that an implant may penetrate right into the submandibular space. And no, I'm not surprised if you are dealing with a situation like that and you don't have a CPCT available, you most likely want to perforate right in there. And that's how it looks like. This is the case, the story of a patient with an intraoperative displacement of the implant, right where I work. Fortunately, we were able to use digital pressure and to push that implant all the way back. So this implant could have been recovered half an hour later after the incident happened. This patient was not so lucky. This patient was actually diagnosed with peri-implantitis, and the dentist tried to remove this fixture. And while doing so, this implant slipped out of his hemostat and got dislodged in even below the mylohyoid muscle. And ultimately, as bad as it sounds, had to be recovered through an extraoral approach. Getting dislodged is one thing. Causing damage is another story. Like here in this situation, the perforation of an implant caused a damage to the salivary gland, and it resulted in a ranula formation, as we can see here. Yeah, that's still handled. But here, what we see here is that a posterior mandible implant perforated and caused a floor of the mouth hematoma. And this hematoma, as we can see here, turned out to be really big and even compressed the airway. Now, also here, this 76-year-old woman. 2, let's say, straightforward, easy implants have been placed in order to give her an overdenture. Yeah. And as we can clearly see here, the implant perforated into the floor of the mouth, and the patient ended up with an emergency tracheostomy. The hematoma had to be evacuated. The sublingual artery had to be ligated. The patient was in intensive care for 4 days. Also here, the perforation of this implant, mandible anterior implant, perforated right into the floor of the mouth, caused a immediate and significant bleeding. Tongue was elevated, so even on site, a relief incision had to be performed to secure the airway. Then a fiber optic intubation was not even easy to do. And so finally, the patient ended up with a temporary tracheostomy for 3 days. Why is it all like that? What is causing us so much trouble? Yes, in one or the other way, it's that sublingual artery. This is that sublingual artery here. And why? Because this sublingual artery ultimately can branch off into an ascending branch, into a middle, or into a descending branch. And we have to understand that on the lingual aspect of our mandible, we will find multiple accessory lingual foramina. They might be small, they may have not a name, but they are large enough to house an artery. And this artery is sufficient in size to ultimately cause a severe hemorrhage during implant placement. Here I give you an example. And typically wise, this medial foramen is the most common. It's actually a high incidence, over 80%. You will look into a medial foramen on the lingual side. And even the lateral foramen has a good incidence, about 10% incidence. What should we know about the arterial supply of the floor of the mouth in order to prevent this from happening? Or if it happens, what to do? Technically, we're looking into 3 arteries: the mylohyoid artery as a branch of the inferior alveolar artery, the submental artery as a branch of the facial artery, and the sublingual artery as a branch of the lingual artery. Now we see the sublingual artery runs above the mylohyoid muscles, while the submental artery runs below the mylohyoid muscle. And they have a lot of communications among each other. So if a bleeding appears, in the first place, we don't know what kind of artery was injured. So according to multiple recommendations in the literature, it's most likely the submental artery. And this should be always ligated first. And if this bleeding cannot be controlled, then we may look into a ligation of the lingual artery. Because we have to understand, if this happens, if we have a vascular trauma, we look into severe hemorrhage. And this will ultimately displace our tongue, our floor of the mouth, and will give us a mechanical pressure on the pharyngeal lumen. And this causes an upper airway obstruction. And that's the major concern. So what to do? So the first attempt, if this is happening to you, is you have to stop the bleeding no matter what. And this means you apply some gauze, some tampons, some hemostatic agent, and don't remove the implant. Leave the implant in place. And of course, you have to refer this patient to a hospital. The patient will be monitored. Yes, in some cases, the bleeding stops by itself. But in the majority of the cases, this requires an intubation, and in some cases, even an additional tracheostomy. And once this is obtained, yes, the hematoma has to be evacuated, and in many cases, the damaged blood vessel, or even the feeding blood vessel, has to be identified and ligated. Yes, so it all depends what happens with this hematoma. If the hematoma is not expanding, we can wait and see. But if the hematoma is expanding, yes, then we have to act. Now we have to intubate the patient. We may have to ligate the blood vessel, and sometimes even to do an embolization and even an extra old ligation of the fetal blood vessel. This hemorrhage cannot only happen in the mandible, it also can happen in the maxillary arch. And we all know this anastomosis. So yes, it's here. When we're doing our sinus lift, this blood vessel can have a pretty good size and diameter. And where is it? Most likely it's intraosseous, but it can be also on the outer cortex, and it can be below the Schneiderian membrane. And it's there. You may not always see it on CT, so the detection rate is somewhere in the 60%, but that doesn't mean it's not there. Yes, and that's how it looks like. This resident, he was prepping his access window, and then out of a sudden, this arterial bleeding disappeared. So the first thing you got to do if this happens, pressure with a sponge, whatever is elevated, and elevate the head. That already helps. And then you try to compress it either with a hemostat or rongeur. You might be even able to, excuse me, to cauterize it with a diamond, but without water. But in some cases, we even have to prep a second window, which is more distal to the bleeding area, and access and ligate that artery from there. If you can identify this artery already on your CBCT, you might even be able to identify, to prep it, and to ligate that artery so it doesn't give you trouble, it doesn't cause you an hemorrhage. Another classical surgical complication during implant placement is also a mandibular fracture. It doesn't happen that often, but there are multiple scenarios, like here, an atrophic mandible, an infected implant site. When we perform a lateralization of the IN, a ramus graft, a distraction osteogenesis, and even peri-implantitis can cause mandibular fractures. You don't believe? I show you examples. And see here, typically was very highly atrophic mandible. And yes, by perforating also the inferior border, that's how it happens, and the mandible fracture. So my advice is, if you are placing implants in highly atrophic mandibles, make sure you have an intact buccal, lingual, and inferior cortex. This will ultimately stabilize your mandible. Also, if you have an infected implant site, an infected surgical site, in a worst case scenario, yes, you may get some localized osteomyelitis, and this can ultimately cause a pathological fracture of the mandible. Also here, the transposition of the inferior alveolar nerve was performed, and 4 weeks later, that's where it happened. I think the problem here was that the implants really engaged here in the inferior border of the mandible, and this ultimately destabilized the mandible, so the mandible fracture. Also here, watch out the ramus graft. See, I think the ultimate goal was here to do a ramus graft to increase the alveolar width. So everything was great at the beginning, but after 4 weeks, the patient was eating and he was hearing a crack, and that's where it happened. But even the result here is very unfavorable. I don't like this one at all. But you see, a mandibular contraction even while raising a ramus graft. Also, distraction, osteogenesis, especially in the atrophic mandible. That's where typically always happens. So please don't do these procedures when your bone height is less than 10 millimeters. 50% of all fractures related to these procedures are happening when the bone height is less than 10 millimeters. Extreme resorption of the mandible is even a contraindication. And also here, peri-implantitis, a progressive peri-implantitis defect ultimately caused this mandibular fracture, especially in a patient like this 72-year-old. She had a history of squamous cell carcinoma, had radiation therapy. So in this scenarios, the infection, the peri-implantitis infection, the osteomyelitis progressed rapidly and ultimately caused a mandibular fracture. And finally, and last but not least, we also have to deal with even life-threatening complications. All these complications I mentioned before, there's in one or the other localized, except the bleeding, but they can be contained. But what if this happens? Aspiration or indigestion of implant parts. Well, it can be really harmless, like in this scenario. So the patient showed up with a cough, and anesthesiologist was able to recover this screwdriver with a McGill forceps, no problem. Here, the screwdriver was aspirated, went all the way down into the lung, and of course had to be recovered with bronchoscopy. Same here, aspiration of implant parts. They may get aspirated or they may get swallowed, indigested. As you can see, this implant, very long implant drill. So at that point, it's really up to the gastroenterologist what to do, what's best. Wait and see, or remove it with gastroscopy. So here, the screwdriver made it finally out of the body. So the minimum treatment which has to be rendered to follow up with that patient. And as you can see here, see this screwdriver within 5 days made it all the way out of the body, no problem. Also here, this screwdriver in 6 days. So 6 days follow up are usually sufficient to follow up. But you may also have this kind of case. See, this screwdriver was followed up after 7 days, after 14 days, no movement at all. So this had to be recovered by colonoscopy. So my advice is, when you're dealing with all these little parts, you use a full pack. It doesn't prevent 100% of these incidents, but it reduces these incidents significantly. And then infections. Yeah, we all know that. And infection can be as harmless as this. But when you see this, you already know something is going wrong here. And the problem with these infections around dental implants is they might be kind of rare, not too frequent, but we all learned that lessons that an early implant-related infection, they don't really respond that well to antibiotics, and most of the time, the implant has to be removed. Yeah, it's just the way it is. And if we don't remove it, this is a significant factor for osseointegration and a classical risk factor for early implant failure. Or we see this scenario here. The implant was placed, the implant site got infected, turned into a localized osteomyelitis. Well, there is nothing else to do in removing that implant, debride the surgical implant site, and another case. 2 implants have been placed, and 1 implant was a troublemaker. You see here, after 2 weeks of placing that immediate implant, patient showed up a perimandibular abscess. Even in the time after that, had actually recurrent perimandibular abscesses. Finally, the implant had to be removed, but like after 6 months, you see that moth-eaten, stippled appearance of the bone in the left mandibular region, even the bone scan showing that there's a lot of things going on. So this only shows, yes, even a sufficient initial treatment with surgical drainage and high-dose intravenous antibiotics was not enough to stop that infection. And that's how it ended. Ultimately, that patient ended with a refractory osteomyelitis and hemimandibulectomy and a partial reconstruction of the mandible. Also, a similar scenario here. This patient, diabetes type 2, presented 2 weeks. I've had 4 implants placed 2 weeks prior to his emergency room visit. Had antibiotics, everything was fine. When he presented in the ER, he had fever, right some mandibular swelling, and on the CT we see all these hypotense areas all the way into the neck. Yes, this patient had really a deep facial abscess all the way here. And of course, the only thing we could do was an incision and drainage to save that patient. Very similar situation in this patient. Although we could not identify a perforation of the mandible into the floor of the mouth, at least we could see this gaseous collection here. So what happened? After 5 days, this patient got really, really very bad. High blood pressure, facial, laryngeal, and tongue swelling. White blood count, way over 22,000. So what happened? On the CT scan, we see a large amount of hypotense areas all the way in the neck and in the lung. Even a pleural effusion in the lung. So what happened here? That patient got a descending mediastinitis. How can that happen? Yes, there are multiple pathways from a simple dental abscess all the way through the deep spaces into the mediastinum. Technically 3 pathways. I don't want to go too deep into it, but yes, gravity and negative interthoracic pressure are certainly facilitating the spread of cervical infections all the way down into the mediastinum. And fine, ultimately, you're looking into a scenario with an infected mediastinum all the way almost up to the heart. So we as clinicians, we really have to be alert. We have to identify these kind of symptoms: fever, dysphagia, redness. If you only placed an implant, you wouldn't expect your patient coming back like that. So that's really our job, because we don't want that our patients end up like this with a surgical drainage, systemic antibiotics, and a lot of supportive medical care. Another case, this patient only had an extraction of socket graft done. 40-year-old female. After 8 days, she showed up with a temperature of 101 Fahrenheit, diplopia, dilated pupils, propoptosis, chemosis. What happened here? And the patient had an abducens nerve palsy. What happened here? This patient ultimately was diagnosed with a cavernous sinus thrombosis, which is a purulent thrombophlebitis of the cavernous sinus. How does that happen? How does this happen? We have to understand infection, especially here in this area, it's called the danger triangles. The veins, the facial veins, they don't have valves, so the blood flow goes all the way into the brain, either through an anterior route, through the angular vein, or through a posterior route, through the transverse facial vein into the paragate plexus. And that's how you get the cavernous sinus thrombosis. And that's really a life-threatening condition. And you see, since there are so many blood vessels in that area, once you have the infection on one side, the infection is in the other side within 1 day. So we as clinicians, we really have to be aware of these clinical symptoms, especially when it comes to any type of ophthalmoparesis, especially our cranial nerve number 60 abducens. That's the first nerve which is involved, and that's literally pathognomonic. If you see that, the diagnosis is for sure, you don't even get an MR scan. And we also see this, brain abscess, implant placement after crestal sinus. Remember that valves of the veins in this triangle of dangers, they don't have any valves. So yes, there is a chance of a spread of bacteria right into the brain and ultimately causing this brain abscess. So what can we do to prevent all this? Yes, I still think a good surgical techniques that involves all kinds of aseptic techniques. Yeah, clean surgery decreases the possibility of contamination of the implant site, and ultimately reduces infections. And yes, and that's my message to you. Yes, surgical complications, they can be significantly minimized. Always make sure, and I'm coming to the end of my presentation, always make sure you have a good indication. That's not an indication. And same here and here. Really good indication. Have always a good treatment plan. Not like this, and not like this, and not like this. Have a clean surgical technique and a meticulous hygiene. Always select a modern and well-approved implant systems. And also have an appropriate design of your prosthetic superstructure, and not like in this patient where there was no match, not on a single implant, there was no match with the superstructure. And so my take-home message for you is, yes, implant placement. After all this, I don't want to discourage you. Implant placement is a controlled, surgical, and very successful procedure. But But even simple implant procedures are ultimately invasive in nature, and they can trigger extremely serious and life-threatening complications. So all of us, whether we are all surgeons or dentists, and no matter how skilled and experienced we are in implant dentistry, we must be at all times aware of this kind of complications in order to promptly plan an emergency intervention. And yes, the lack of complications and inappropriate surgical techniques are really key factors for successful implant treatments. And in order to answer my questions from the beginning, are complications a result of poor decisions? Well, let me answer these questions with the words of Dr. Einstein. Good decisions come from experience, and experience comes from bad decisions. I personally wish you always that you make good decisions based on your experience. And I want to thank you very, very much for your attention, that you attended that webinar. It was a big pleasure for me. And whenever you want, I will see you again, no matter where, I'll be back. And thank you again.
Thank you. That was a wonderful presentation. Thank you for putting that out. I have a couple of questions I would like to you from the staff and also from the participants. What are your immediate recommendations if you know you violated the safety zone of 2 millimeters and hit a nerve?
If I really violate, well, first of all, when I place an implant really close to the nerve, I would always probe my osteotomy. You can probe. You should make sure that this osteotomy is surrounded by bone, especially to the lingual and especially to the apical part. If I really have evidence that I violated it, it all depends on my CBCT evaluation. If I only impinged the nerve, I may only back it out, replace that implant with a shorter implant, and that's it. If I see the nerve is exposed, I would put it into some topical dexamethasone, put in a collagen blob, and let it go and let it heal.
Well, pray to the gods, right?
And pray every day, exactly.
So you're saying you widen your walls, maybe take a fatter implant, shorter implant, and try to engage it?
If, let's say, if you are sure that your nerve is intact, it's not really impinged, it's absolutely okay to either use a shorter implant or a wider implant. But if you have direct access to the nerve canal itself, if the nerve is really exposed, I personally would recommend don't do another implant, don't do a bone graft, only place some topical a dexamethasone, wait until the situation is resolved and do it again. First of all, you want to make sure that nothing happened to the nerve. The implant can be delayed. That's not an emergency procedure, but a problem with the nerve, I personally, that's my regimen, and that's what I recommend to the residents. Yeah, we don't want to risk for that. The implant, you can place that implant at any time. Yeah, but if you really see there is a problem, the nerve is exposed, the nerve is even transectable, that's it with the implant. Yeah. I hope that answers the question.
Yeah, absolutely. Absolutely, it has answered the question for the person, but there's a follow-up question here. It's okay. How is a migrated implant removed from the nose?
From the nose, usually with the ENT people with an endoscope. If it's in the nose, it's in the endoscope. We use the endoscope. If it's in the sinus, we have actually two approaches. We can do the oral surgery approach, which is the lateral window, the Caldwell lock, or still, FES surgery is an option, but the only disadvantage is that if you are using FES surgery to recover an implant from the sinus, you will have to remove the uncinate process to get access. So sinus, rather the oral surgery approach. If it's definitely in the nose, an endoscope, that will do the job.
The follow-up question is, how do you clean the sinuses when they have become full in all the spaces? How do they clean those? We understand how they clean sinus.
Well, if it's completely infected, well, what you got to do is you have to make sure, yeah, that all that granulation tissue, all that infectious tissue is removed. And in most cases, you have to also to assure that there is a good drainage into the mouth. So we usually have to perform a little window towards the nasal cavity so the sinus can be drained. That's very important, especially in chronically infected sinuses. So yes, you have to surgically clean it, make sure there is no oral communication. The patient has to be on antibiotics. It's definitely more a complex procedure, especially if you're looking into a fully infected sinus caused by a foreign body. I remember even the case where the patient had kind of a fungal infection due to a displaced implant. Yeah, this infection has to be cured. And then after half an year, this patient will be reassessed whether he or she can have another implant. At that stage, it's unpredictable.
Wonderful. Wonderful. So yeah, it's quite an interesting ordeal to clean the sinuses. Sometimes infections come back and you can't get your bone grafting done to put your implant, and it becomes a big circus for a while.
Absolutely.
So here's a hot topic, partial extraction therapy and implant placements. What is your take on that?
Partial extraction, well, it certainly works in some hands. I never tried it. That's not our objectives, how we teach the students and how we teach our residents. Well, as far as I know the literature, and I followed it up, and along with one of my residents, we even made a poster on that. We reviewed the literature. Oh, it certainly works if it's performed the right way, absolutely. But the negative thing is there is no standard protocol. Everybody is doing this a little bit different, and you have to stay with certain rules. And well, I'm sure if Dr. Gutmann is doing this, he may have excellent results, and probably if somebody else who is not as well versed doing that, he may have adverse outcomes. But my point, I think it's too early to call it a gold standard. The idea is actually great because we are preserving a piece of the tooth, and we are kind of fooling our body that we actually did not remove the tooth, so the buccal wall can be preserved. I think it's now all about the details to develop a kind of a standard protocol so that all of us who are really interested in these techniques can just follow this protocol. As far as we reviewed the literature on that topics, there are a lot of animal studies, and healthy teeth have been extracted. That's what we usually don't do. So, and there is not really a uniform protocol how much and how to design this socket shield. But that's, I think it's going to be crucial and make all the difference.
I've seen all kinds of numbers, Doc, from 1 millimeter to 2 millimeters to 1.5 millimeters. You should leave the distance between the root membrane and the edge of your implant. So
that's my point. It's very, there are too many opinions out there, and I think what it takes, I think the time is right to do it now, to develop a kind of a standard protocol. That's how the technique should be performed, and that gives you predictable results.
Very good. So you mentioned something about not yourself and the university promoting this particular procedure, but I read some things about New York University having an opinion on coronectomies, which is sort of a partial extraction.
Yeah.
What is the consensus over at New York University on coronectomies and how they should be best performed?
Oh yeah, coronectomy. Well, that's certainly another type of partial odontectomy. I was more or less looking into that socket shield thing. Well, we actually were doing a lot of odontectomies. See, if we see, and that's pretty much our workflow. If we see a wisdom tooth, a mandibular wisdom tooth, which has at least radiographical signs of a really critical proximity to the inferior nerve, we would do a CBCT. And if we see these kind of signs that the root tips is really right at the canal or in the canal, yeah, then we do the odontectomy. As long as there are no contraindications, such as gross caries and all this kind of stuff. And actually quite successful. It's certainly a good alternative. And as far as I know, we did not observe any nerve damage. And maybe in about 20–30% of the cases, yes, the patient comes back because the root started to migrate and the roots has to be removed. I know in the literature, this is kind of considered to be like a failure of the coronectomy because we need a second type of surgery. But still, I wouldn't call it even a failure. We preserved the nerve, and actually so far there was not even one patient who complained about that he had to undergo a second surgery. Yes, if indicated, it's a very good alternative, to be honest with you. But on the other hand, well, if there is a good chance to recover the entire tooth without significant risk for the nerve, we should still look for surgical techniques how to remove the entire tooth. But if this seems to be impossible and the individual who is performing the procedure is leaving the comfort zone, yes, an odontectomy, a coronectomy is absolutely okay. Absolutely okay.
What's the key? Just removing all the enamel?
That's absolutely the key. The entire animal has to be removed because, as we all know, there is no such thing like an animal bone contact. So yes, that's really good. So you have to be within the roots. All the animal has to be removed, and you have to do an X-ray before you suture up, so you really are sure that all the animal is removed. That's where you get a problem. Absolutely correct.
That's great to know for our colleagues, Doc. So as long as the enamel goes, our risks are really low to actually encounter infection.
Always check mobility. So the thing is, the remaining roots should be non-mobile. If there is mobility, you better take them out. That could give you some trouble.
So here's a question that brings it all together for the session, for your topic that you were presenting today. Which implant complications should GPs refer immediately to oral surgery or the hospital?
Which implant complication? First of all complications where you are leaving your comfort zone. It can be very simple, and they can be life-threatening. I think when I was talking, at least any kind of, once the implant disappears in the throat, whether it's swallowed or whether it's aspirated, doesn't matter. This patient belongs to the emergency room. Of course, this kind of bleeding in the floor of the mouth, I think this should not be handled in an outpatient setting. The emergency procedure, that you try to compress that bleeding, that you try to stop the bleeding as good as possible. That's what you're supposed to do in your private office. But you better have this patient brought over to the emergency at that point. When it comes to nerve damages, as we said, well, that's pretty much based on your what really happened. But I think if you have any kind of hints that there is a partial or a complete transection of the nerve, this patient should be referred actually immediately. And we know, meanwhile, yes, an immediate reconstruction is certainly beneficial. So
what percent? I mean, if you were to put a number on it, what's the percent of recovery you get from a complete transaction?
More than 50%. I think I was listening to a webinar recently, and they have really great success. And this was a person, I think, University of Miami. They are really have great success with early and even late reconstruction. I think many good things are happening on this, and maybe in one of my future webinars, I plan to contact that person. I want to try to work that in, or it's really amazing with new techniques, with a new approach, how many of these complications can be resolved. But in general, my recommendation would be, if you observe a transection or a partial transection, this patient goes to the hospital right away. And if you're leaving your comfort zone, because the complete paresthesia lasts longer than 4 to 6 weeks, rather an early referral than a late referral, because you want to avoid a neuroma formation. You want to avoid that. Okay.
Wonderful. Well, that's something that gives a lot of us sleepless nights that are doing a lot of implants with guides and everything else. As you know, the guides are good, they're accurate, but they're not always 1000% accurate either. So We are always struggling with the idea of causing permanent damage to someone, even though we treatment plan properly and we do all of the different steps. Anything can happen during surgery, as you know. I've heard stories from you in Germany when you were doing your residency with orthodontics and bleeding everywhere and all that good stuff. Anything can happen. But Dr. Thomas, with that note, I don't have any other questions from the audience right now. Is there a final message you want to give our young and upcoming implantologists to keep plugging away and care for the millions of people that need this treatment?
I think my best message is really make sure you really stay with continuous education. I do the same, and I'm doing this now more than 25 years. We never reach the end. There is always something new to learn, and especially in these times, I can tell you, I was watching a lot of really excellent webinars. So it's really be informed, never leave your comfort zone. And this comfort zone is very different depending on the level of your training and in your education. And you will grow, you will get better. But at the point, stay in your comfort zone, continue with your education. I think that's the best way to achieve excellence and to minimize complications and learn about the complications. I think that's crucial. The one who can handle complications going to be the king in the future.
That's right. That's a great message. Doc, one more question came in, if you may have your time to answer it. Actually, two more now. Did you perforate the sinus membrane to drain the sinus infection cyst? If you do, how do you repair it afterward?
Okay, good question, actually. Yes, if it's an antral pseudocyst, I may only have whatever a needle. I perforate, I aspirate, and I do a very small incision in the Schneiderian membrane, maybe only 2 or 3 millimeters. And once I aspirated all the fluid out of the pseudocyst, I will be able to grab that pseudocyst and literally pull it through this little perforation, and I will even try to suture this perforation or cover it with a membrane. Yes, it's doable, but you really should be sure that this is an antral pseudocyst. It's only filled up with some kind of serous fluid. If the fluid is really kind of mucus or it looks infected, we better remove that cyst first. We wait a couple of weeks and then we do the sinus lift. But a classical antral pseudocyst, you can aspirate it, you pull it through that perforation, you repair the perforation, and you proceed with your sinus lift. No problem.
Wow, if you stick around, Doc, you're gonna be here all day answering questions. I got one more, if you don't mind.
No problem. Afterwards, day goes on. Okay, one more.
So you mentioned dexamethasone in application, and one
Yes.
Dr. Mahendra is asking if, in case of nerve injury, how do we apply all of the local medicines?
Well, you can you can soak it up in a gel form in some kind of collagen plug. You soak it up. You put it in the osteotomy. Put a figure of 8 suture on top of it. That's it. Very simple. I would put maybe 2 or 3 drops right into the osteotomy and close it with a gel form of any kind of collagen plug. That's enough. You should be fine. It only helps. See, it will not cure it, and it's only indicated if there is no partial or complete transection of the nerve. It's like when the nerve is impinged, but in itself still intact. It reduces the swelling. It reduces the inflammatory processes. So you most likely will see a short recovery. And please don't place the implant and don't bone graft it. As you don't want to push all the bone graft into the canal. Really, just
what happens if somebody ends up with that scenario?
With what kind of scenario?
With having pushed bone into the canal.
Oh, well, depending on the clinical situation, but most likely what happens, if this can be clearly identified in the CBCT, yes, this is impinging the nerve, and then we have to address it. That means we will have like a lateral approach with a piezo to the mandibular canal, and this can be removed.
Wow.
Yeah. But we should try to avoid it. So if it happens, please don't push any kind of particulated bone graft material into that socket. It's not necessary. Really, first you care about that nerve, later on you care about the implant.
Wonderful. So with that said, doctor, I'll go ahead and conclude this session. Thank you so much for your time. Couple of housekeeping items. And we will have, pertaining Dr. Wiedemann, you're welcome to visit the extacademy.com to see Dr. Wiedemann on the U.S. tour this year, and hopefully in additional international locations in the next year and the following years. Feel free to visit extacademy.com, and you will be able to find much information there. As far as the Global Interdisciplinary Summit will continue for another 26 or 27 days until the end of May. Please continue to share, inform our colleagues. Our mission is to reach up to 1 million dental professionals from around the world that otherwise don't have the access or the finances or the ability to travel to up their knowledge and skills during the COVID time. We thank you for all of your support and participation in this project, including Dr. Wiedemann and all the faculty and all the presenters and all of the attendees. The links are listed below. Feel free to come in and watch the daily complimentary webinars, register for CE to get CE if you need it for your licensure, and we look forward to being of service to all of our dear dental colleagues and friends around the world. Thank you so much, Dr. Wiedemann.
You're welcome, and thank you, Dr. Shah, for the invitation. It was a great pleasure, and many greetings to all around the world, to our great colleagues, and I hope to see you again somewhere, sometime. Goodbye for now.
Thank you, sir. Have a nice day.
Have a nice day. Goodbye.